Hi everybody, I'm Stephen Johnston and I'm just really happy to be here today. And before I get started with my talk, I just want to say thank you to everybody, in particular Dr. Shinogle's family, to the Public Policy Department, to Dr. Salkever, the Economics Department, my fellow students, and also my family. It's just an incredible honor to be here and to be associated with Dr. Shinogle's name. And I'm really thrilled to be here talking with you today. So as for the agenda for my talk, I'll provide a little bit of a more personal introduction about myself. Then I'll spend the majority of the time talking about some shared research interests that I have with Dr. Shinogle. In terms of general common ground, I'll talk about briefly some of our professional research that overlaps, and then I'll get into an overview of my proposed dissertation research, which is closely, somewhat related to some of the research that she's done in the area of prevention. And then I'll conclude by discussing some of my recent research, recently published research, some ongoing research, and some future studies that I'll be working on. And then I'll open it up for discussion. So in terms of my path to the present, I started attending UMBC as an undergraduate in 2000. And after bouncing around several different majors, I think I looked at religious studies and art history, and finally landed on economics, thankfully, and was able to sort of flourish in that role. After that, during that time, I met my wife, Christina, over here in 2003, and we met on campus, just kind of kept bumping into one another, and I finally got the courage to ask her out, and 5 years later, we got married. So we are both UMBC alumni. I joined the Economic Policy Analysis Master's Program in 2005, and I was able to score a research assistantship with Dr. Salkever, and that was very formative for me, and I learned a lot, and it led to really the path that I'm on today. I started working at what was MedStat, now Truven Health Analytics, in January 2007. And I've been there now for almost 7 years. And after working there for about 2 years, I sort of wanted to go out in the field and decide whether or not getting a doctorate was the right thing for me. And I realized that that's really sort of the industry card, and I should do it. So I came back to the public policy doctoral program part-time in 2009. So I finished up some classes, and I'm now working on my dissertation very, very, very slowly. So. And then another big thing in life is that I had a daughter, Victoria, also known as Cora, back last year in May. So here's a picture of my family, Christina and Cora. This is Easter this year. And then that's Cora in her Halloween costume. She dressed up as a sheep because she likes sheep, and I think her first word was bah. So in terms of common ground that I have with Dr. Shinogle, we're both professionally involved in an area called pharmacoeconomics and outcomes research. She was a member of the International Society for Pharmacoeconomics and Outcomes Research, which is ISPOR. She frequently spoke and was a panelist at those conferences, and she didn't know me that well, but I knew her name and bumped into her at the conferences frequently. So pharmacoeconomics and outcomes research is a couple of disciplines that combine economic analysis with epidemiologic methods to study health-related research questions that oftentimes look at the impacts of pharmaceutical and medical interventions. Some of our specific shared areas of research, so I got to go through her CV and sort of see where she and I had areas in which we had both published, and I saw there was really a lot of common ground there. We've both done studies on HIV. She did studies specifically looking at the use of antiretroviral medication, and those are some studies that I've been involved in as well. Smoking cessation, my master's thesis wasn't specifically on smoking cessation, but it looked at the impact of cigarette taxes on whether people would switch from branded to generic cigarettes. And then also I did some subsequent research professionally on the topic of smoking cessation and whether health insurance benefits covered smoking cessation treatments and what impact that had on individuals' health. She did studies on management of chronic conditions. Specifically, I think heart failure was one of the topics that she investigated. And I've done some studies that are similar in acute coronary syndrome and diabetes. So that's another area in which we share interest. Pharmacovigilance and adverse events. She did a number of studies, I believe, looking at adverse events in the hospital setting. And I'll talk about a couple of studies that are similar later on, but pharmacovigilance is basically looking at whether people have adverse events after they're prescribed a drug and how often those happen and how can you prevent them. Medication compliance and persistence. She did a couple of studies on medication compliance and persistence, and that's an area of research that's interested in how well you take your medications relative to how they've been prescribed to you. So taking, for example, HIV, people with HIV who are treated with antiretroviral therapy, they often have to really religiously take their medications every day. If they don't, if they miss a few doses, their viral load can increase, and that can have adverse health consequences. So there's this whole area of research about how well people comply to their medication, what are the predictors of compliance, and oftentimes these studies try to correlate medication adherence and compliance with health outcomes. So she was involved in that, and I've done some studies on that, specifically also in the area of HIV. The effects of prescription cost sharing on medication utilization. She was I believe that was some of the research that she had presented at ISPOR, and she had a paper on looking at that. And that's that's very closely related to medication compliance and persistence. And essentially, it has to do with how much people have to come out of pocket to pay for a medication. So if you're, say, on Medicaid, well, maybe that's a bad example, but if you're commercially insured and all of a sudden your copayment goes from $50 to $100, and you go to the pharmacy and you go to fill your prescription, it's possible that maybe you won't be able to afford it and you'll wait a few days. Again, that's a form of poor adherence. So this type of research often looks at the correlation between cost sharing, so how much you pay out of pocket, with adverse health outcomes that result from poor medication compliance. And then finally, one area of research that we've both been interested in is epidemiology. So that's just generally looking at the incidence and prevalence of diseases. An example would be, beyond just the incidence and prevalence of diseases, maybe looking at things, sequela of diseases. So maybe in diabetes, how often does someone get diabetic peripheral neuropathy, which is a pain condition that develops in diabetic patients, and what are the predictors of that? Who tends to get it, men or women, just risk factors for various different health conditions. One of the common themes throughout Dr. Shinogle's research was prevention, and I know that she had done some research more recently on obesity and preventive interventions with obesity, and that I'm going to talk about my dissertation, which also is oriented towards prevention as well. So I'm going to use that as a segue, and then again I'm going to talk a little bit later on about some of my current and ongoing research in the area of prevention. So my proposed dissertation research is entitled Evaluation of the Effects of Early Childhood Interventions on Young Adult Earnings, Examining the Relationship Between Proximal and Distal Intervention Effects and Subject-Level Heterogeneity. And so I'm speaking Greek to my wife and my dad right now, but hopefully I'll be able to explain it a little bit better. Again, my mentor is Dr. Salkeever. So just to talk a little bit about what is the definition of an early childhood intervention? So we all know that there are various environmental factors that can affect children's health and their health trajectories. Things like exposure to lead or other poisonous substances can have detrimental impacts on their health. There are infectious diseases that can have lasting impacts if you get them at a young age. So similarly, those are biological exposures that impact children's health, but there's also social and psychosocial relationship sort of exposures, so early life experiences and relationships that can have an important role in child development. So for example, if you are raised in an abusive household or exposed to violence at a young age, that can have a lasting impact on you for the rest of your life. So early childhood interventions, it's really a broad range of services and programs that are designed to provide some sort of support or enrichment for children. And these programs are often targeted at people who are in need or disadvantaged. Early childhood interventions have been shown to have numerous effects, and those effects typically vary by the types of services that are provided. So some of them are more health-oriented, and they'll provide things like meal services, nutritional counseling. Some of them are focused actually on parental skill development. So in past interventions, nurses and social workers have worked with parents to improve their sort of child caring skills, and that has obviously different sorts of impacts than nutritional services. And then there are also behavioral and educational interventions, which focus on poor academic achievement or maybe poor behavior in school. So the effects of these interventions can both be short run and long run. So short run effects include effects on children during their school age years. So things like improvement in grades, test scores, school attendance, measures of social functioning, juvenile delinquency. And those more long-term effects are things that show up in the adulthood years, and those include educational attainment, so maybe secondary education and college, whether or not individuals are employed, the level of income and earnings that they have, and then they can also result in reductions in use of social services, so maybe income support, and things like criminal activity. So the effects of childhood interventions not only necessarily benefit the individual, they can also benefit society at large if there are things like reductions in crime. So getting into the theoretical sort of economic underpinnings of the research, the model of human capital and skill formation, which is probably most synonymous with the name Becker, looks at the effects of investments in humans and the process of skill formation that affect the ability of individuals to earn income. So investment in humans, that's things like education. So if you graduate from high school or if you graduate from college, you're more likely to earn more than individuals who haven't done that. Healthcare, if you're healthy, you've got a better chance of being gainfully employed and productive at work. And then on-the-job training is an obvious one. If you gain skills that help you be better on the job, that can help you earn more income. So the traditional model of human capital and skill formation expressed lifetime as basically two time periods, childhood and adulthood. So investments in childhood would affect adulthood, and investments during adulthood would also affect adulthood. But that was sort of a constrained, just a simple model of really how investments can affect individuals over time. So recently, Cunha and Heckman extended that model to a recursive form where an equation for the nerds in the room. We've got child skills in a given period, T, are a function of a parental characteristic, so sort of what you inherit from your parents. That doesn't really vary with time. The child skills in the prior period, and then parental human capital investment in the child skills in the prior period. So this can have multiple periods of time. So what that's saying is, if you invest in a child during preschool, that will potentially have effects in elementary school, which can have effects in middle school and in high school and so on and so forth. So it's a much more flexible model. And there's all sorts of kind of brilliant stuff that they came up with that I won't go into, but this directly relates to my dissertation. So the problem that my dissertation is addressing is that there's a huge amount of evidence that early childhood interventions are beneficial. We should do them, but the fact is that they're very costly. It costs money to implement an intervention. It costs money to evaluate an intervention over time. If you have children and you want to follow them into adulthood, you have to track them down. You have to pay people to go collect their data, all that stuff. It's just very costly. And then it's also costly to replicate interventions. So if we did an intervention in Baltimore County and we wanted to do it in Howard County, that costs money as well. So in order for people to be, public policymakers to be willing to invest in interventions, approaches that maximize the efficiency of implementing and evaluating and replicating the interventions are critical to the economic feasibility of them. So my study is going to use longitudinal data from the Johns Hopkins Prevention Research Center intervention trials. So these were interventions that were given to children back in the 80s, and they've followed the children who are now adults up until very recently. I think the most recent, there are still data being collected, right? So in those trials, they've got this really rich data set that has information on children's characteristics when they were young and their employment outcomes, their education outcomes, and so on and so forth. And I'm going to be conducting empirical analyses that evaluate the impact of the randomized classroom-based childhood interventions called the Good Behavior Game and Mastery Learning on their adulthood earnings. So I'm looking at the effects of these interventions on adulthood earnings. I'm going to have 3 essays. The first will be a systematic literature review, which I won't really talk about today. And then the second and third will be empirical analyses, and I'll focus on providing an overview of those. So a little background on the interventions. The Good Behavior Game rewards children for appropriate behavior in the classroom. So the way they do this is they divide the classroom up into 2 or more teams, and in each team, if a child displays inappropriate behavior, they'll give a point to that team. So it's sort of like reverse peer pressure. You don't want to be the one who gets your team a point, because at the end of the day, they give the team with the fewest points some sort of a reward or a prize. So it's an incentive for children to behave and compete against one another in good behavior. The Mastery Learning Program is an educational program targeted at poor school achievement. I won't go into the details, but the difference between the 2 programs is that one targets poor behavior, the other targets poor school achievement. So essay number 2, which is the first empirical analysis that I'll conduct, in terms of its background. So early childhood interventions, as I discussed before, can have both proximal or near-term outcomes, such as educational attainment, and distal or long-term outcomes, such as adulthood earnings. So the concept of this is that if the proximal intervention effects can account for a substantial amount of the distal intervention effects, they could be used, evidence that there are proximal intervention effects can be used as an early indicator for success of the program. So if you see that a program in the short run is resulting in better grades or better high school graduation rates, that provides an incentive or justification rather for continuing the intervention, for investing in long-term follow-up of the intervention, and then also for replicating the intervention because it's obviously got at least these short-run benefits. And this is a similar concept for those of you who are familiar with clinical trials to surrogate endpoints. So in clinical trials, they'll often measure short-run short-run outcomes that correlate with the ultimate thing that they're trying to prevent. So an example of that would be blood pressure and cholesterol changes in the trial of a drug that's intended to prevent acute myocardial infarction. So in terms of the objectives of this analysis, I plan to evaluate the impact of the two interventions on the proximal outcome of educational attainment. And then I want to examine the relationship between the intermediate outcome of educational attainment and the distal outcome of early childhood earnings. So in terms of the analyses, I plan on doing this in the framework of a recursive model that looks at the indirect intervention effects on earnings and the direct intervention effects on early adulthood earnings as well. So basically, it's like a simultaneous equation that looks at educational attainment as a function of the intervention, and then adulthood earnings as a function of educational attainment and the intervention. So in the second equation, educational attainment will absorb a lot of the long-term effect of the intervention, and what will be left over for the intervention is sort of the direct impact of the intervention on earnings. So you've accounted for the impact that the intervention had on educational attainment. So the significance of this particular essay will be that it's going to provide one of the first assessments of whether near-term evaluations of interventions can be used to gauge the early success of interventions, sometimes maybe decades ahead of the time that you're actually able to observe the full long-term effects. And so that information could potentially be used to improve the efficiency of long-term evaluations of childhood interventions. So if you see that a particular intervention really isn't having much of an effect on short-term outcomes, that might be a reason not to invest in long-term evaluations, and then the converse is true as well. And I'll take questions at the end, I suppose. So the second empirical analysis that I'm going to do, some background. So I introduced the recursive model of human capital and skill formation before. One element of that is that it also states that subject-level heterogeneity can affect the productivity of investments in both current and future periods. So what that means is basically different people will respond differently to human capital investment. So if you think about an intervention that targets poor children behavior, you don't want to round up all the kids who are super well behaved in class and subject them to a behavioral intervention. That's probably not going to do much, and it might be a waste of resources. Instead, you'd want to target that intervention towards individuals who have poor behavior, because they're the ones who are probably likely to benefit from it the most. So early childhood interventions can vary according to subject-level heterogeneity, whether it's, again, their behavior problems. It probably depends on the intervention. It may vary according to their socioeconomic backgrounds. And these effects have been demonstrated empirically, and they also have important practical implications for efficiently targeting interventions to those who will need it the most. So if you have a behavioral intervention, maybe it's not good to make it a universal one so everybody in the classroom gets it. Maybe you want to just target the people who tend to have the worst behavior, and therefore you're spending less money because it costs money to sometimes implement interventions on a per subject basis. So the objectives and analyses that I plan for this essay are to examine the relationship between subject-level heterogeneity and the impact of the two interventions on early adulthood earnings. We'll look at treatment interaction effects or stratifications by characteristics such as socioeconomic status, early aggressive disruptive behaviors, because a number of papers have shown that these two factors, there are some heterogeneous treatment effects for these particular interventions based on those characteristics. And then a new thing which I'm going to investigate and I'm sort of nervous about, but is the presence of single nucleotide polymorphisms that correlate with aggressive disruptive behaviors. So they've collected genetic data on individuals who are in this longitudinal study, and SNPs, single nucleotide polymorphisms, are genetic markers that have been shown to be associated with things like aggressive disruptive behaviors, addiction, substance abuse, things like that. So it's possible that some individuals will be genetically predisposed to characteristics that might be that might be good for targeting on the basis of what am I trying to say here? Individuals with certain SNPs might be the kinds of people who you want to target for an intervention. So that's what I'm trying to say. So the significance of this essay is that it's going to provide an assessment of whether the earning effects of the two interventions vary by subject level heterogeneity. And the importance of this is that if they want to replicate these interventions, they could say, okay, well, people with lower socioeconomic status and this SNP tend to be the ones who benefit the most from the interventions. Let's try to target them. Of course, there's all sorts of potential problems with genetic screening of people when you're going to target them for an intervention. There's lots of practical limitations around that, but at least we'll investigate whether that's a possibility. So that's a quick overview of what I planned for the dissertation, and now I'm just going to quickly talk about some of my recent, ongoing, and future research related to prevention. So one of the studies that I did recently, which is one of the ones that I found really, really interesting, was entitled Patterns and Correlates of Linkage to Appropriate HIV Care After HIV Diagnosis in the U.S. Medicaid Population. So that was recently published in Sexually Transmitted Diseases. It's like a clinically oriented journal. And basically what we did in that study was we looked at patients who had Medicaid coverage, who were newly diagnosed with HIV, and we followed them over time to see whether or not they connected with a healthcare provider who would administer these two tests that are sort of the bare minimum for getting patients the treatment that they need, so viral load and CD4. And what we found in this paper was that a really large proportion of HIV patients who are on Medicaid don't link up to appropriate HIV care. And that's got a very important preventive and public health implications, because there's this big unmet need that these patients aren't getting linked up, and they don't know whether they need antiretroviral therapy, and therefore they're at risk for developing AIDS and other that can have other really bad health consequences if you initiate therapy late. There's two forthcoming papers in the American Journal of Health System Pharmacy and Pain Medicine looking at the prevalence of potential drug-drug and drug-condition interactions in chronic pain patients initiating pregabalin or duloxetine. So pregabalin is an anticonvulsant and duloxetine is an antidepressant. They're both used for the treatment of chronic pain, but they're very different from one another in terms of their risk for drug-drug interactions and interactions with comorbidities or other conditions that individuals have. So what we did in this paper was we looked at people who were initiating one of these two drugs, and then we looked at the period of time prior to it for about 1 year. And we looked at what health conditions they had, and then we also looked at the other medications that they were prescribed around the time period that they got pregabalin or duloxetine. And we were able to show that a large number of patients were prescribed the drugs despite the fact that they had other drugs that could potentially interact with that drug. And people who have serious chronic pain conditions are also often treated with polypharmacy. They've got all kinds of drugs they're taking. So in this paper, we were able to demonstrate that A, one of the drugs is sort of safer on average than the other, and then B, that there's a lot of potential inappropriate prescribing. And again, this has a preventative public health message in that there's a lot of this going on, and maybe certain providers aren't aware of it, and they're not being vigilant enough about the conditions that people have and the other medications that they're taking when they prescribe these drugs. And a lot of times they're constrained because the insurance companies tell them what they can and cannot prescribe, and that can lead to inappropriate prescribing. So third bit of research that we completed recently was examining the patterns and correlates of osteoporosis medication use after hip fracture. So people who have a hip fracture are generally found to have low bone mineral density when they receive a DEXA scan or a dual X-ray absorptiometry scan. That's how you diagnose, one of the ways in which you diagnose osteoporosis. And we found in this study that among about 100,000 hip fracture patients, only 20% of them were prescribed an osteoporosis medication within a year after their hip fracture. And it is really shocking because this is one of the most effective ways to prevent future hip fractures. And so the gist of this study, again, it's preventative. There's this unmet need. There's probably just some patients shouldn't get the medications, but the majority of those who didn't probably would benefit from it. So that one's under review at the Journal of the American Medical Association. They've had it for 2 weeks and haven't rejected it yet. So I don't know what to make of it. It's a long shot. Another study it's similar to the pregabalin duloxetine one, is looking at the prevalence of risk factors for atypical antipsychotic adverse events and the consequences of inappropriate atypical antipsychotic prescribing. So in that study, we looked at individuals who were starting any one of a variety of atypical antipsychotics, and we looked in the year prior to that period, and we characterized what health conditions they had, and as well as the prescriptions that they were taking around the time that they were prescribed their atypical. And we were able to demonstrate that there's a fair amount of people who don't necessarily get the optimal medication. So a good example of that is olanzapine is associated with metabolic syndrome, and that can be really bad for individuals with diabetes. But we found that there was a fair number of diabetic patients who were prescribed olanzapine despite the fact that you generally just don't want to do that. So in this study, we looked at that, we looked at the prevalence of that, and we're actually taking it one step further, and we're just about to start this research where we're going to compare patients who got like the right drug to patients who got maybe the wrong drug. So we're looking in subsets of individuals who have the specific contraindication is, I guess, what they call it, who have it. So one of our groups is diabetes patients, and we're looking to compare diabetes patients who received olanzapine or I think it's quetiapine also is associated with metabolic syndrome, and we're comparing them to patients who received aripiprazole or ziprasidone or risperidone, which aren't associated with metabolic syndrome. And we're going to see whether the patients who got the wrong drug are different from the patients who got the right drug in terms of how long they stay on their medication, whether they switch to a different one, and whether they have increased healthcare utilization and costs, like, do they get hospitalized, do their diabetes costs increase, things like that. The results of that were presented recently in October. That's a long conference. I must have the dates wrong on that. October 3rd. I thought that said 30th. So the U.S. Psychiatric and Mental Health Congress. And finally, the last study that I've got going that's related to prevention is a study that we just started, and it's looking at the prevalence of risk factors for anti-diabetic medication errors. So there's this class of diabetic medications called DPP-4 inhibitors, and when you use these medications, you have to be really careful about how you prescribe and dose them to people who have renal impairment. And diabetic patients are at high risk for renal impairment. So we're looking at the prevalence of renal impairment, the severity of renal impairment in the general diabetes population, as well as those who are prescribed these drugs in particular. And we're going to look at the frequency of medication errors, and sort of the ultimate message of that paper will be that you have to be, really vigilant about taking care that you're giving the patients who have renal impairment the right dose. So we don't know what the results of that will be, obviously, but so that's the last of this list of studies that I've got going related to prevention. And so, in conclusion, I just want to say again how much of an honor it is to receive this award and to have to be associated with Dr. Shinogle's name. I'd say that, you know, for anybody who's interested or looking for certain research topics, I encourage you to look into prevention-oriented research. There's thousands of questions out there that haven't been answered, believe it or not. I know you sort of go around, you look for a topic, and you think there's nothing new under the sun, but there are subjects, and there's a lot to be investigated still. And I think that kind of research really falls in line with Dr. Shinogle's legacy, and you know, I hope I can do justice to the award and to her name in the future. So, thank you all very much.
I have one question for you. You mean to tell me that snips has nothing to do with the scissors?
I'm not sure what they have to do with just yet. So.
Okay, so I've got some questions. It's a very rich research agenda. On your essay too, and the Heckman-Kuhnha literature, they commonly make this distinction between cognitive and non-cognitive skills, which I didn't hear you mention. I was wondering how you would bring that in. For example, that you could bring that in as sort of a proximal distinction between cognitive and non-cognitive proximal outcomes. Right. So I was wondering about that. A second issue is differences by gender for both essays 2 and 3. There could be different reasons why that could occur. I was wondering about that.
Yeah.
And then a final issue, one area that I think could have some policy controversy about this, focusing on the early childhood one, it raises the issue of the family versus the school, especially the secondary school. So it raises the issue of, do you want to put most of the policy resources into early, family issues versus the issue of, by the time you get to secondary schools, it's too late to do anything.
Right.
So those are some areas I was just wondering if you would want to comment on.
Sure. So the cognitive, non-cognitive piece, I think so if I get it right, the non-cognitive skills are sort of inherent behavioral traits. This is a part that I haven't investigated a lot for my dissertation, and I think it would be good to...
Not necessarily inherent. I mean, one commonly measured one is simply attending school regularly.
Right.
So that would be viewed as sort of a non-cognitive skill. Right,
so your suggestion is to try to incorporate that as an intermediate outcome of interest and add that to the second, both the first and the second equations. So we actually discussed a little bit about that and a whole variety of different intermediate outcomes that might ultimately affect earnings. And I think ultimately a lot of it's going to depend on some of it will depend on what a statistical software package will allow me to do in terms of estimating multiple equations at once. But I think it's a really good idea, and we were talking about not only things like school attendance, but juvenile delinquency as being an intermediate outcome that would be really interesting to look at. So that's a good suggestion, and I'll definitely try to incorporate that. The second one you had was gender differences, and that is definitely something that we plan to investigate. There have been several papers that, actually many of the papers specifically looking at this cohort of individuals typically split the analysis by boys versus girls. And that's certainly something that we'll have to do, because they've shown that the impacts on boys for certain outcomes are much stronger. And then actually, I think for girls, the educational impacts are stronger, if I remember correctly. So that's definitely something we plan on doing. So the third one was, I can't remember.
Well, a crude way of putting it is by high school, is it too late to do anything, so you don't worry about high school?
Oh yeah, that's an important discussion point, and in terms of the way in which it'll affect this particular analysis, were constrained by the way that particular intervention was implemented. But I think there will definitely be that argument that, do you invest in the school-based setting versus in the family-based setting? And I know that some of the interventions that have had the strongest and most obvious and lasting effects are ones that have incorporated that parent skill development, those elements. So I think that's a really interesting point.
I was going to make one other comment about David's question that last week, because it turns out that it's kind of complicated in the prevention area. You're frequently hearing it's better to intervene early. So the early is going to definitely get more payoff to intervening early. And it turns out when you think about it, there are really two possible things going on there. It's very hard to distinguish between them. One is, do you do essentially the same intervention at an earlier age? And the other is, do you wait and do a very different intervention? Now, the latter question, I think you can address. The former question, that it's essentially the same intervention, just you really should do it, say, in kindergarten versus second grade. As near as we can tell from just doing literature review, nobody knows. No one has ever actually run that kind of experiment. And it's considering how strongly people push this idea that the earlier the intervention, the better. It's probably worth at some point trying to investigate that.
Are there other questions? Well, I want to thank Stephen again.
Thank you.
Oh, yes. Almost forgot.
Probably no surprise for you in reading it. We would like to give you this plaque.
Thank you.
You're quite welcome.
All right.
Again,
It's really an honor. It's really an honor. Thank you so much.
All right, thank you, folks, and we'll meet outside.
This is nice. Thank you.